Hello, everyone. I'm Jamie Panetta. I'm the program director for the San Diego Independent Scholars Organization, or SDIS. This is our monthly lecture, so welcome. Glad you could make it. If you're not familiar with SDIS and would like to get more information, make sure you sign in and give us your contact information, and we can send you notices of talks and other things that go on in the organization. The speaker this month, we're happy to have Dr. David Weissman. He is a recent member of SDIS, I believe, right? Yes, you joined, yeah. And so let me just read the little blurb that we have here. Dr. Weissman is a retired medical oncologist, and palliative medicine specialist. He's a UCSD grad and the first palliative care physician in Wisconsin. He is professor emeritus at the Medical College of Wisconsin. So in this talk, he will focus on people who fear being overtreated at the end of life, as the end of life draws near. This talk hopefully will give you the language needed to have discussions with your health providers and your family to help ensure that your wishes are honored. So we're happy to have you here and take it away.
Great. Thanks so much.
You can get.
Unless you need. Okay. Greetings all. Hi. You're all here on a beautiful Saturday afternoon. I can't imagine why. But thank you for coming. And for those on Zoom, welcome to this talk. A friend of mine said, you know, you're going to give this talk and they're going to want to know what happened to this. And all I'm going to tell you is I had an accident and you really don't want to know how it happened. So we'll just leave it at that. Some of you in the room actually, I know do know what happened, but we'll leave it at that. But the bottom line is they say I'll have a full recovery. So all that as well. I need to learn about you. Why are you here? What brought you here today? What questions did you have that you were hoping to get answered?
You made us come.
Thank you, John.
Well, I have a question.
Yes.
My husband is in memory support
Okay.
and he's at the stage now where he has a little trouble swallowing every so often.
Okay.
And it's not at that stage yet, but for other people with him, it is that then they start to aspirate food
Right.
and they start to get recurrent pneumonia.
Yes.
And the question is, at what point should I say to the caregivers, well, don't send him to the hospital to treat the pneumonia?
Great question. Great question. And I welcome my Zoom participants, if they have questions, to shout them out, because I'm told that, are they hearing me okay? Yes, sir.
So I can tell you why I decided to invite you to give a talk, and that's because I thought this was an issue that is normally not discussed in our society very much. Issues of end of life and how to talk to your doctor or health provider about it. I thought it was an important issue.
Yes, sir.
I'm the other side of the coin. I notice that the older I get, the more paranoid I get about
Paranoid about
my health.
Yes.
You know, like coughing, or I have a cough or something. I don't know exactly how to. My doc, who I've had for 25 years, she goes, you know, you're in great health. You know, we're watching you closely, but I still get twinges of, oh my God, there's something wrong.
Well, my wife is a retired psychiatrist. She deals with paranoia, so I'll give you her name.
Actually, I'm a psychologist.
Oh, well, then you and she can talk about it together. All right, if I don't address that specifically, you can bring that up in the question period?
Yeah.
Yes. What else? Yes, sir.
Well, I don't have.
And by the way, we're gonna make this very informal. I'm David. I only make my children call me Dr. Weissman. It's fine. Introduce yourself.
Okay, I'm Tom Packer.
Hi, Tom.
And one of the large, I don't have any particular issues, but the but it's good to know, okay? It's an important topic, period.
Yeah.
But also because I deal with communication with people when they're in a difficult situation.
Yes,
So I thought there, would be input about, how do you talk to people in general in a difficult situation?
excellent, excellent, great. Yes, sir.
I'm generally an optimist, but I'm interested in the context of assisted suicides.
Okay. And what specifically about assisted suicide?
Well, how it stands in terms of sort of, interface between legal and, medical issues.
Okay.
Yeah.
All right, we can talk a little bit about that.
As presented in Switzerland.
I'm sorry,
As presented in Switzerland, they have suicide thoughts.
as presented in Switzerland, yes. Okay,
Yeah, I have a question if I can.
yes, sir.
Yeah, so basically, a long time ago, my wife and I gave the hospital where we have all our medical practitioners a sort of living will and basically in there it describes the kinds of things you'd like. In paragraph form, I explain exactly what I think I would like in terms of something happens to me and should they or should they not resuscitate and things like that. And my question is, if something happens to me and they rush me to the hospital, who's going to look at that thing? Who's going to have time to look at it? And why would they bother looking at it? They're just going to go ahead and do what they want to do anyway. That's my sense of it. So am I wrong about that? And how does that work?
Not entirely wrong, but we'll talk about that. Good question. But you're
Jerry-
absolutely, and you should take his paranoia because it's good to be paranoid about this to protect yourself. So we'll talk about that.
Jerry Kay has a question.
Jerry Kay. Hi, Jerry.
Good afternoon. I think we're all hoping for the perfect timing of everything that's going to happen. So it's going to happen now, it's going to happen a month ago, 2 years from now. How do we figure out the timing that we obviously have no control over and no certainty of what's going to happen to us?
Right, next question. Jerry is my cousin. Listening in from Northern California. Yeah, good question, Jerry. We'll get into all this. That's great. More. Yes,
What about 5 wishes?
5 wishes. I'll talk about 5 wishes. Great. Other things. Let me ask you a couple of questions. Do we have any health professionals in the audience? I heard a psychologist. I know you.
LCSW.
LCSW, good. Retired or still working?
Sort of.
What kind of practice?
Individuals, couples.
Okay.
And I was the first hospice social worker in San Diego.
Really?
A long time ago.
And which hospice was that?
It was San Diego Hospice.
San Diego Hospice.
We were just a little office.
Yeah.
On the team.
Fantastic. Any others here? Yes.
Well, it depends what you mean by professional in my mortgage paying value rating days. I was a lawyer, but now I am a mindfulness innovator and developing difficult response to any kind of difficult circumstance in mind.
Fantastic. Excellent. Thank you. Okay, and I get the sense that some of you are currently dealing with these issues now in your own family, as you are. Just raise your hand if it's a current issue for you. Okay. So this is a difficult subject we're going to be talking about today. It's an emotionally laden subject. My goal is not to heighten any emotional anxiety about this, but to give you some options of different ways to think about how this moves forward. Just a bit about my background. Born in San Francisco, grew up there, came down to San Diego in the 70s, went to medical school here, met my wife, stayed on as a resident, and then we moved away. 36 winters in Wisconsin. So I spent my entire professional career in the state of Wisconsin, retired 6 years ago. This is actually the first medical professional thing I've done since I retired. I've been doing other things. And then we moved back 2 years ago because we always wanted to come back to San Diego. And I'm absolutely delighted to be back here in town. It's funny though, it's changed a little bit in 4 years. Some of you may know that. All right, I'm going to go through some slides. It's not a huge deck. It'll provide all the basic legal, ethical, medical issues and provide some context. And then we're going to go into much more Q&A and try to answer all your questions. I don't have anywhere to be this afternoon. I know they have to close at 3 o'clock, but if you have questions that go after, we can talk about it. Oh, and one other thing. I had a license to practice medicine in California when I was here, but I don't have one now. I'm not a licensed California physician. I still have my license in Wisconsin, which doesn't do me much good here, but I still have it. But I am up to date on California laws and policies that reflect this issue. So that's the provision. So I can't write you all the prescriptions you want to do assisted suicide as you go out the door. Not me, can't do that. All right, our objective today is to learn how and why to have serious conversations with your healthcare provider. And my guess is that this is what most of you want to prevent. This is a slide. I really don't know where I got this. It wasn't a patient I took. I probably came out of a magazine article. But as you notice, the elderly man hooked up to a ventilator with his arms tied down. You can walk into any intensive care unit in the country and find many people like this. And when people of our generation get together, generally people say, I'm not sure what I want, but I know it's not that. That's not how I want to go. And the theme of today's talk is that this is largely, not entirely, largely preventable if we communicate. And the problem getting there has been a failure to communicate between patients and families and their clinicians, patients, families and their friends, is that we don't talk to each other about these issues. So we're going to talk today about how to talk. And the result of this is incredible patient-family suffering, incredible health professional moral distress. You're familiar with the concept of moral distress? It's when we feel like you have to do something because it's your job, but you don't want to do it. I can tell you that nurses who work in intensive care units, adult, pediatrics, psychiatry, who are forced to do things that they don't want to do and think is morally wrong, the moral distress is unbelievable. And there, of any group, it's the nursing staff that suffers because they spend the most time with the patients. Overuse of medical interventions near the end of life, we know about that. It leads to ending up in the ICU, emergency room. We call it the revolving door in medicine. People coming in and out of the hospital who really have no business being there, but no one knows what else to do with them. They die in the hospital, and the cost, emotional, physical, social, societal, is extraordinary. And we're very, very good at this in this country. Because, you know, in Great Britain, what they say about Americans is that you think you can live forever and treat your patients like that. It's a cultural philosophy, not exclusively the United States by any means, but we are definitely kings at it. We have nailed this bit really well of not knowing how to deal with this. Okay, so we have a collusion of silence. Doctors hate discussing prognosis. If I look back on my career, I would say that I spent a large part of my career trying to get doctors to do the right thing. Patients are easy. Families can be a little more challenging. Doctors are a pain in the butt. So we'll talk a lot about that issue. But families are afraid to ask. They don't want to talk because if they talk, they ask questions, they might get news that they don't want to have to deal with. Patients almost always want to talk, but they're inhibited by their families or their clinicians. Oh, Dad, you shouldn't ask those questions. You're going to be fine. That was a common phrase. Until very, very recently, doctors had no training in leading these conversations. Now, all doctors are trained in how to do CPR. You all know what CPR is? I don't have to explain that. Very few doctors are trained in how to have a conversation about CPR. Very, very few. And the whole world of end-of-life communication training has only started in the last 20, 25 years. So that's really had been a new phenomenon. Okay, so I need to tell you a little bit about my practice to understand where we're going. So I trained as a medical oncologist, and my interest was in neurologic complications of cancer. I went to Wisconsin to set up a brain tumor program, which is kind of the worst of the worst in the cancer business. You know, it's just kind of ugly stuff. But I got there and there was some interesting thing happened in the state of Wisconsin around cancer pain and getting better involved in cancer pain. And I got very involved in that. And that led me to go to a meeting in 1990, up in the mountains at Estes Park, you know where Estes Park is, up in Colorado? And it was a meeting called the Academy of Hospice Physicians, a small group of 100 doctors who were interested in hospice work. And at that meeting was a doctor from Scotland and a doctor from Canada who got up and talked about this new field of medicine called palliative care. It was started in Canada in the 70s, spread to Scotland, England, and was just beginning to happen in the United States. And I came back from that meeting and said, that's what I want to do. I want to be involved in that phase. I was never into the chemotherapy side of oncology. I like to talk to people. I like to talk to sick people. I like to take care of sick people. But the actual making people sick with chemotherapy was never what I wanted the medicine for. So I came back, and after 3 years, I had enough money from grants and this and that. I hired a nurse, and the two of us literally hung out our shingle in the hospital and said, we're the palliative care team. Call us if you have pain, problems with pain or nausea, or you're not sure what to do, prognostication, whatever you might need. And I had already gotten a reputation as somebody who knew a lot about pain. So we started getting consults. And this case was a case that I had dozens of these over the years. This is what I did for the last 25 years of my practice, was run a palliative care consultation service. We would be in the hospital and then in the clinic, see patients. So I got this call one day, Friday afternoon. It's always a Friday afternoon. Sorry, I had to take some medicine, which is drying out my mouth. This was a 67-year-old patient with lung cancer, was in the intensive care unit, and the doctor said, we're asking you to see them because the family's not realistic. We would get 3 of these consults a week. The family's not realistic, which means the doctors all think it's hopeless, but they can't convince the family. So I go in and do my thing, and the first thing I say is, what have you been told? And the family's sitting around a big room. The family says, well, the doctor said the kidneys are not working, the liver's not working, the lungs are failing, there's fluid around her heart. And they keep talking to us about wanting to put a needle to remove the fluid around her heart. We're not sure if we should do that or not. We don't know what's going on. I had already gone to see the patient and seen that this was where she was. And so I turned to the family and said, oops, wrong. I said, your mother is dying. And their response was, well, if she's dying, then of course we don't want any of this. Please allow her to die peacefully. Can we take her home? And that was the time I learned the power of using the word dying. Nobody in medicine wants to use the word dying. It's a scary word. It's really a tough word. You don't want to use that. But it's one of the few non-ambiguous things that doctors can actually say. Mom's dying. So that's case 1. Case 2 is a 74-year-old with pancreatic cancer. And her oncologist says to her, the cancer is not responding to the chemotherapy. We could try another combination of drugs. Why don't you think it over? The patient's response was, am I dying? The doctor's response was, we're all dying. A different kind of response might have been, has anyone talked to you about what to expect in the future? Would you like to talk about it now? And so this is all about the communication failures we have in medical practice. This was actually a family member of mine. And when the oncologist walked out of the room, the family member looked up at me and said, okay, what's going on? Yeah, what's going on? She said, am I dying? I said, yeah. And we had a conversation. Okay, so this has gotten a lot of attention in the lay press in the last 15 years. There have been some nice books written. How many of you have read Atul Gawande's Being Mortal? One of you, okay. The Conversation. There's some wonderful resources now for clinicians to learn communication skills. Vital Talk is really the premier program in the United States where young doctors go and get training in how to have these communication. So there's been some really nice work done has really helped move the field forward. So what we're going to talk today is about 3 conversations, and we're going to talk about each one in a little bit of depth. There's the advanced care planning one, and somebody told me that they had filled out a form their living will. That was advanced care planning. You did something in advanced care planning. The advanced care planning conversation is really about determining a surrogate decision maker, and we'll talk who those are. We'll talk about big picture values, about what your big picture values are. And the issue of specific desires is a little complicated. We're going to talk about that. Often people put a lot of things down on this forum when they're well that maybe don't belong there at that point in time. So that's conversation one. Conversation two, we call the serious illness conversation. This is if you've been diagnosed with a serious and potentially life-threatening illness. And that conversation is really between clinicians, should be between, actually, it looks like I left something off. Yeah, the advanced care planning is all adults over the age of 18 need an advanced care planning document. My perfectly healthy children, I made them fill out a document. This is not something for when you're sick. This is something when you're healthy. The serious illness conversation is when you're sick or have something that potentially could be sick. And that's a conversation between you, your healthcare team, and your family. Talk about what's the current and future course, what can I expect? What are your goals in context to prognosis? And what concerns you? What are you worried about the future? This is a wonderful, not wonderful, but a necessary conversation to have when you're not at death's doorstep. The third conversation is is really the end of life conversation. And this is what I used to do day in and day out in the hospital. Mr. Jones is in the ICU. Mrs. Smith has failed all the chemotherapy. She's declining. It's the conversation of where are we going? What's happening here? Again, it's about setting goals. It's talking about prognosis. It's about end of life planning. Where are you going to be? Who's going to take care of you? What about future hospitalizations? This is the questions you have about your husband. When do we involve hospice in this? So that's we call it the goal of care conversation. It's usually a family meeting. Okay, so what about discussion opportunities? I show this slide for a couple things. The y-axis is functional disability. That is, how disabled do you get over time? And the timeline until death. And in adults, and I assume it's probably true for children too, John, is there are really two patterns of functional disability in illness. One is what we call the cancer curve, and it's amplified by colon cancer. And you're really pretty, but you can substitute any cancer up there. People with cancers are very functional, typically until the last 3 months. And by functional, I mean they get up, they get dressed, they're able to eat, they go shopping, they can get out of the house. Last 3 months, boom, bottom drops out. So we have a very well established that if you're spending more than half the time of your day in bed or laying down or resting with cancer, you're looking at 3 months or less. You're looking at that kind of time frame. Are there outliers? Of course, but there are outliers both ways. So it's that's a very predictable end of life course. For all other diseases, and I put here congestive heart failure, but you could substitute Alzheimer's, chronic kidney disease, emphysema, any other chronic disease. It's a much slower decline over a period of years, marked by periodic exacerbations, sometimes, not always, where you have to be hospitalized. And what's true in the last year of that is that you never quite get back to baseline. The curve is going down. So you've had an event, you're in the hospital for 3 days, you go home, you're always weaker when you go home, and you never quite are as good as you were before you went in the hospital. And that's a good marker that you're in the last year or so. And what's important about this curve is that the death is actually sudden and unpredictable. Now, somebody asked me a question about predictability. I think it was my cousin Jerry. It's unpredictable in that the patient with congestive heart failure has been the way they've been for quite a while on Sunday night. And on Monday morning, they have a stroke and are dead. And you couldn't have predicted it Sunday morning, the day before, that that was going to happen the next day. So they develop a heart attack, they have a stroke, they get an overwhelming infection, boom. So that's that kind of death is very hard to predict at the end. We're good at saying within 6 months, but in there, even in that, it's pretty wobbly. We don't have good predictive markers for things less than that. Okay, so let's talk about the advanced directive conversation. So this is about the form. It's all adults, healthy or sick. It's about you having a discussion with your family and friends. Forget your doctor for, you can keep them out of it. This is really a conversation between you and your family. And the discussion is about what's important to you, what gives your life meaning, what you do or don't want happens, best you can say it, and who can speak for you. And what of the things that's most important about this discussion, it's getting some of that issues down, but who is your surrogate? When a patient would come into the hospital who was not able to speak for themselves, the very first thing I would do is go to the chart, if they had it, or ask the patient, do you have a form to designate a surrogate? You asked about being paranoid, so no, not the paranoid question, about what happens to those forms. And the answer is 80% of the time, nobody looks. And they just go ahead and do what they want to do. And it's the role of the surrogate to say, stop, I'm the surrogate decision maker. My loved one has lost decision-making capacity, I'm in charge. And legally, they have the power, all the power, to make medical decisions. Start antibiotics, stop antibiotics, go to the ICU, not go to the ICU. All power, and it's all statutory, all 50 states. So it's a very important element. The two problems are that one is oftentimes no one knows who the surrogate is because the patient filled it out and never talked to the surrogate. Oh, I'm making decisions? I didn't know that. And two is they feel powerless in the medical system because the medical system is overwhelming. Mrs. Jones, you need to do X, Y, and Z to save your husband's life. Okay, doctor. And that's the nature of the medicine, the practice. Okay, so most important is the discussion with loved ones, choosing a surrogate decision maker, completing a document and keeping it handy. So if you come to my house and open the freezer, you'll find our advanced directives in it. My wife knows where it is, I know where it is. Don't put it in your safe deposit box. Okay? People who are sick and often are back and forth to doctors and healthcare providers put it in their glove compartment. So freezer, glove compartment, somewhere you know where it is. And you're going to send copies to if your surrogate's out of town, make sure they have a copy and make sure they know where it is. You want to give it to the healthcare provider. And the systems are set up pretty well, the electronic medical systems to have these. And some are better than others at retrieving. Don't rely on them. Have your own copy with you. Always give one to your provider, whether it's Scripps or UCSD or what do we have, Sharp, whatever. But always keep your own and bring it with you. And it is by law, it's actually law that they have to ask you when you enter the hospital, do you have this? But that's all they ask, yes or no. Next question. The answer is yes, I have it. Keep a copy. Don't let go of one copy. Keep it on your own hand. The most important thing for surrogates is to be able to stand up and say, I'm in charge. Talk to me. I can't tell you how many people I used to see. They'd be in the ICU for a week. The form is on the chart. Nobody's talked to the surrogate. And the surrogate hasn't come forward to say something. So that's really, really common. So in California, you have a legal document. It's called the Advanced Healthcare Directive Form. You can download it from the web. You don't need an attorney. You don't need a notary. You just need, I think it's 2 signatures. It's a statutory form. It spells out the legal protections for the clinicians so they can feel comfortable. It spells out the legal protections for you. Just go online and look California, just type California Advanced Directive and you'll get to that site. You can download the form if you don't have one. All the healthcare hospitals, I'm sure, have them if you ask somebody. They will typically send you to a social worker or sometimes clergy. It's usually social worker or clergy who can help you fill them out if you're not sure. Somebody mentioned 5 Wishes. 5 Wishes is another kind of advanced care planning document. It is legal in all 50 states. It's a great form. It has much more depth where you put things about it has places in the form about what's important to you and how you want to die and where you want to be. It's a great form. You can have And I don't know if any of the hospitals here supply 5 wishes or not. I bet some of them do. But it's nice. So one word about advanced directives. You gotta, if you're healthy, really healthy, I generally recommend that people not put anything too specific in there. I don't want this, I don't want that. The reason is it ties people's hands. Now, a surrogate, if you've had a discussion with a surrogate, the surrogate can say, I know it says that on the form, but I prefer you didn't do that. The clinicians are supposed to do just what it says on the form. And sometimes it creates problems because things happen that are unpredictable. And it may be a short-term benefit to get something that you thought you didn't want 30 years ago. So I generally recommend people keep specific provisions put very little in there to leave that open, as long as your surrogate knows what's important to you and can be available to say, you know, I know what John would have wanted, and that's what we're gonna go with. That's a much safer way to go than kind of getting into these battles about, well, what does he really want? Is that really applicable now? So just be careful about that. Yes, ma'am.
So your surrogate doesn't have to have everything written down specifically in order to speak for you.
The surrogate has to have nothing written down,
Okay,
except that on the form, you're designated as the surrogate.
yeah,
All that means is that if I say, as the clinician, I say, you know, your husband can no longer make medical decisions. And California, that's all it requires is one physician to write that in a statement. It says, I believe that Mr. Jones doesn't have decision-making capacity. That's what it's called. Then I'm going to turn to you and say, you're the decision maker. Let's talk about what that means. Yeah.
Can the surrogate usurp your healthcare directive?
Legally, well, actually, this is really a tricky question. Are people hearing the questions?
I didn't agree.
Okay, all right, one second. Can the surrogate usurp what's written down by the patient? They're not supposed to. But I can tell you many clinicians will bow to the surrogate because it's easier to bow to the surrogate and avoid conflict. But in fact, they're not supposed to. It's supposed to be, if the patient wrote that, that's what they want, the clinician should follow that. And that's when you have to get ethics committees involved and it gets messy and things like that.
does the surrogate have to be present in person?
No, surrogate does not have to be present in person. We deal with surrogates all over the country, all over the world. Yeah. Yes, sir.
Because if an adult child does not have a designated surrogate, would that default to a parent?
What a great question. The most appropriate decision maker is that person who has a close, caring relationship with the person, is aware of the person's values and beliefs, and is willing and able to make the needed decisions. This person may or may not be the person's next of kin. California does not have what's called a surrogacy law. About half the states do. And what those laws do is specify an order of decision maker. Spouse, adult children, third cousin twice removed. It goes out in order. Wisconsin didn't have this law. California doesn't have this law. There are pros and cons to having either way. So what it means though, and I actually like not having the order. What it means is if family member A is nuts and is demanding something, I can say, well, that's great, but the consensus of the rest of the family is that we don't do that. And so we're going to do that. As opposed to legally, if the spouse is the next of kin, in those states, I have to do what the next of kin says, which may make no sense whatsoever. Okay, starting the conversation. And again, this conversation is when you're well, not sick, with loved ones. I need your help with something. It's important to me that we discuss future plans in case I get sick. Can we sit and talk about it? Hard decisions, hard conversation to get started. With your healthcare provider, I have completed an advanced care plan. I mean, you're welcome to talk to the healthcare provider about it, but doctors don't have time to fill out these forms with you. That's not out there for you. Here's a copy for our records. Blank will be my surrogate decision maker. And then discuss any specific things that you do have with them and see how they feel about that. May result that you may make a change depending on what they say. But this is really a conversation primarily between patients and families or whoever their loved one is. We had a case once where we had a man who lived above a bar. He had no family. His surrogate, we turned out, was the guy who ran the bar. He had known him for 20 years. That was the closest relative. So he said he would stand up and do it. So surrogates doesn't have to be family. They don't have to be present. It makes things a lot harder, but it's not impossible. Yes.
How do you get the hospital to notify the surrogate? I think part of the problem is that they don't know that the person's sick.
Right. Somebody has to be the voice. Somebody has to do that. And that's not easy. There's no, if somebody comes in who no one knows where they're from, or they're not a member of their system, they may have an advance directive locked up in a lockbox somewhere that does the healthcare team no good at all. And believe me, we actually would like to have these forms. They make our life way easier to have these, even though a lot of the docs sort of say, but that's why it's a required question on admission to the hospital. Do you have an advanced care planning document? You're just yawning. Okay. All right. I'm giving you an example of what's called the Junkerman statement. This was known in Wisconsin. Carl Junkerman was a very well-respected internist and bioethicist. And he came up with this statement 35 years ago, and it's really stuck with me. I value a full life more than a long life if I've lost the ability to interact with others and have no reasonable chance of regaining this ability, or if my suffering is intense and irreversible, even though I have no terminal illness. I do not want to have my life prolonged. I would not ask to be subjected to surgery or to resuscitation procedures, to intensive care services or other life prolonging measures, including the administration of antibiotics, blood products, or artificial nutrition and hydration. It nicely summarizes the way a lot of people feel. And this is something you can put into your advance directive because it's not specific. It says, I don't want X. It's if these conditions are met, I don't want X, Y, and Z. And I'm happy to forward that to say, if we can send that out to somehow the people. That's great. Okay, number 2. That's the advanced care. Second is the serious illness conversation. This is between patient, family, and health provider, setting of a serious or life-threatening illness. What should I expect in the future? And that people want to know about function, what can I do, and what kind of symptoms am I likely to have? Is it going to be painful? Am I going to have shortness of breath? What is important? How do you want to spend your time? What's important through this illness? And I guarantee you, patients will never say, I want to have another colonoscopy. It just doesn't have, oh no, I'm sorry, John, you would. Yeah, that's right. Yeah. Otherwise, it just doesn't happen. What worries you? What are the concerns you have? And if you allow an open conversation, people will talk about, well, I'm worried about leaving my spouse. I'm worried about some debts. I'm worried that I haven't seen my third cousin twice removed in Toledo, and maybe I'd like to get to them before things get bad. And then setting personal goals in relation to prognosis. We got to talk about prognosis a bit. You can't set goals without knowing where you're going. If I told you that your prognosis was 1 month, my guess is your goals would be a little different than if I said, 5 to 10 years, not a big deal. It's the most important thing to transmit to patients and families. No one wants to talk about it. So we're going to talk about it. So it's quit beating around the bush and just tell me how bad it is, doc. And the patient's being fitted by the Acme cloth manufacturer. Discussing prognosis. Prognosis is about time and function. In all my years of practice, probably the single most common question I got was, doc, how much time do I have? Every patient has this question. And if they don't ask it, I know they're thinking about it, and I would open the door for them to ask the question. This is universal. I found this among all cultures, all beliefs. everybody wants to know this. If they got a sense that time isn't limitless, they want to know how much time. Now, once they've asked the question, it doesn't mean they always really want to talk about it. So I would always ask people, is this something you really want to talk about? And sometimes they would say, well, on reflection, maybe not. That's cool. Doctors hate this question, absolutely hate this question. They're afraid of they think they're powerful enough to make you lose hope. Big mystery for doctors is they're not that powerful. Doctors cannot make patients lose hope. Patients get bad news all the time. What do? They go to UCSD for a second opinion. They go to Scripps, get a second opinion. We're just not that powerful to make people lose hope. They're afraid of being wrong, which to me is just bizarre. Yeah, so if you told them 3 months and they live for 6, you think they're upset? How does that work for you? But part of it is a fear of failure, that I've failed them as the clinician. And this is particularly true for those in surgical specialties, where this is a real issue for them. They have a different kind of relationship with patients, and it's I'm saying in a good way. I can tell you I have a wonderful relationship with my hand surgeon, so. So they obfuscate, and the common responses of doctors are, only God can tell. Everyone is unique. You want to keep living, don't you? There's no way to know. We have more good data on prognosis. We could sink a ship with prognostic data. There's tons of data out there. We can't tell you what day you're going to die. Can't tell you what month you're going to die. But we know it's coming. And we can say something. So if you're in a situation where you want to know, whether it's at this conversation or the next conversation, and nobody's talking about it, they're dancing around the issue, you can prompt them and say, I know this is difficult for you, but I need some idea how I can plan for how I want to spend my time. Are we talking days to weeks, weeks to months, or months to years? Those intervals are much more comfortable for clinicians to talk about. And you can prompt them and ask them that. And if they still give you nonsense, then it's time to get some help. So you seem reluctant to discuss this with me. Who else can I talk to? And this was a common referral to the palliative care teams. So in 1993, when I hung up my shingle as a palliative care doctor, we were one of 3 in the country doing that. Now they're in every hospital in the country. UCSD has a big program, Sharp has a program, Scripps has a program. And you can say, I want to talk to the palliative care clinician. That may be a doctor, maybe a nurse, it may be a social worker, most likely a doctor or nurse. So there's no easy way I can tell you this, so I'm sending you to someone who can. So a word about palliative care. I've used the term, what is it? This was traditional medicine before palliative care. You did life prolonging care until the very end. And then if you were lucky, you got enrolled in hospice, and then you died and had bereavement care. 40 years ago, when I started in practice, less than 20% of dying patients ended up in hospice. Now it's close to 50%. The length of stay in hospice, though, has really not changed over the last 40 years. It's still only about a week. It's still very short. In the 90s, palliative care came out, and the goal was to integrate palliative care with life prolonging care. So I would see patients in clinic for often years who had a terminal illness, but who had issues that I could help them deal with. And then at some point, transition them into hospice. The goal of getting longer hospice care has not panned out. We can talk about that. It's another issue, but let's leave hospice care out for the moment. What's in the syringe? What do we do in palliative care? We do symptom management, we do prognostication and communication, we help establish patient-centered goals, and then plan for the future. So it's 4 elements. So if somebody's calling palliative care, doesn't necessarily mean you're dying. We saw lots of patients who didn't have a terminal illness, but just had something serious. I saw a lot of patients with very chronic pancreatic diseases, vascular diseases, just to help out with pain, symptoms, and goal setting, but they weren't necessarily on death's doorstep. Oops, wrong. And this is how I think about palliative care. We're the intersection between patient's family and the healthcare team. bringing the medical reality in line with everyone's beliefs, hopes, and emotions. It's sort of a melding of those issues. The outcomes, we've got a lot of research now in palliative care. We reduce time to symptom relief, improve satisfaction, earlier hospice referral, reduced readmissions and hospital deaths, reduced ICU days, a lot of reduced cost. Typically, hospitals really want palliative care services, and doctors don't want palliative care services because we end up stopping lots of things. No, you don't need another colonoscopy next week. It's not part of your goal. That takes money out of the GI's pocket. People always ask, what's the difference between palliative care and hospice? Palliative care services are appropriate at any point of serious illness, provides the same as life-prolonging treatment. It's paid for just like any other insurance medical procedures paid for. There's no prognostic requirement, no need to choose between treatment approaches. In the United States, it's largely provided in the hospital. There are some outpatient programs, and there is some home care palliative care. Those are both big growth areas, home palliative care and clinic-based palliative care. A lot of hospices now have home palliative care programs to get patients involved earlier who then transition into hospice. Hospice has the same principles as palliative care, but it's combined with a health insurance benefit. So in 1974, Congress passed the Hospice Act, which established Medicare benefit, hospice benefit. If two doctors certify that a patient has less than 6 months to live, if the disease follows its normal course, they're eligible to sign off of Medicare Part A, which is their hospital benefit, sign on to the Medicare hospice benefit, which provides a huge range of services for patients and families, largely designed to keep them at home. You can get hospice and long-term care. That's been the huge growth industry in the last 20 years. And for patients who can't be managed at home, who have real serious needs, they can be in the hospital, and hospice will provide the services in the acute care hospital. Okay, last conversation is the family meeting conversation. This is my wife used to call it the Moses conversation, the parting of the waters. Dad's been in the hospital for a week, not doing well, going downhill. Everybody's frustrated. Where are we going? Call palliative care. Have them meet with the family. It's usually in the setting of declining function. It's, again, goal setting and a lot of planning for the future. Are there resources to take care of you at home? If not, we've got to find another resource. What are we going to do about future medical interventions? Yes, no, maybe. Rule of thumb, and this is a rule of thumb you can take for future medical treatments. If the test or treatment will not help toward meeting the stated goals, then it should be discontinued or not started. I used to get a million of these questions. Well, they got that thing on their finger, the pulse ox machine. Do we need that? Is it meeting any goal? No, then turn it off. Do we need to do glucose monitoring? Is it meeting a goal? No, turn it off, stop it. These are the kinds of ways you answer whether treatments are appropriate or not. I'll skip that. Okay, a couple more forms to think about. One is pulse. How many have heard of pulse? Physician's order for life-sustaining treatment. This is now legal in, I don't know how many states, over 30, I think. This is a legal medical form. It's only for people with a serious illness or advanced frailty. It's voluntary. You don't have to fill it out. It's a process, discussion with the healthcare provider, completion of a document with signatures. It stays in the medical record, doesn't expire, but it can be revoked or changed. And the medical order, so these are physician orders, apply to these things. CPR, yes, no. The level of medical interventions, full, selective, or comfort focused. Artificial nutrition, yes, I want long-term nutrition. No, I only want trial of nutrition. No, no artificial means at all. And last, the signatures. And there's a form, it literally goes in the medical chart. It's all right signatures to the doctor. And that goes with you. You go to a nursing home or care facility, and those are the orders. It's a wonderful thing, particularly with Alzheimer's disease and dementia patients. Less applicable to the cancer patient just because of the timeline. But anyone with a long-term declining illness, these can be very nice. It is again legal in California. It says Pulse California. I encourage these. A lot of doctors feel uncomfortable with them, don't know about them, don't know how to use them. find somebody who does. Okay, and then the last couple comments about common procedures that come up as conflict issues. One is CPR. This is the single most contentious issues between patients, families, and healthcare team in the seriously ill, by far, whether or not to do CPR. And the reason is because 98% of doctors will walk in and say, Mrs. Jones, do you want us to restart your heart if it stops? That's the CPR discussion. Well, sure. Why not? Well, the why not is because it rarely works and it has a lot of complications. And it's a medical procedure. It's not just putting a blanket on somebody. We put tubes in people, we break their ribs, can break their ribs. It's not something you want to undergo. So the success rate, if I keeled over here and somebody called EMTs, the success rate of getting me back to full function is under 20%. And I'm healthy. If you take somebody who's chronically ill in a hospital setting, it's almost zero. It's barely above zero. So clinicians should, but usually do not, make a clear recommendation based on actual data. The data is what I see in front of me. Gosh, I see somebody with cancer all over their body who weighs 90 pounds, who spends 90% of the time in bed. You're not going to survive. No, I'm not. I'm going to tell you that when you die, I don't recommend trying to restart things. And those are the words I use. When you die, I'm not going to try to restart things. And that's a conversation, a different kind of conversation. Unfortunately, most clinicians have no idea how to do that. We have lots of training seminars, try to teach people this, but it's a tough nut to crack. What about artificial hydration? This is the second most contentious issue. By artificial hydration nutrition, I mean any procedure that goes beyond normal oral ingestion of food and liquids. So it's basically sticking tubes somewhere. Sticking a tube down your nose and your stomach, sticking a tube into your stomach to provide feeding, putting fluid in through an IV. This is all considered artificial hydration and nutrition. They're medical procedures, they're not ordinary care, they have risks and benefits, which people normally don't generally think about. But there are considerable risks of problems. And one of the risks you saw in that first picture with the guy in the ICU bed, his hands were tied down. The reasons their hands are tied down is because he was pulling out tubes. You take somebody, put them in the ICU, they get agitated. If they have a feeding tube in, they want to pull it out. And so what we end up doing, we have to tie people's arms down. There are few things you can do that's more dehumanizing to people. As somebody said, you make them wear striped pajamas, you tie their hands down. What does that sound like? It sounds like jail. So it's a hugely emotional issue for families and healthcare staff, medically, legally, and ethically. It's totally acceptable to not start or discontinue if the procedure does not meet a stated goal of care. The goal of care is to get dad healthy enough to get out of the hospital, and there's a good chance that he can do that. Well, then by all means, it makes sense to do it. If the goal of care is to let dad die and let that death be as peaceful and comfortable as possible, then it probably doesn't meet that need. So that's a very interesting, difficult conversation for patients and families and healthcare providers. A lot of nurses have problems with this. A lot of doctors have problems with this. Some of it comes, religion will get in the way of this. And you'll get the comment, well, you can't let them starve. And you have to reframe that. And there are ways to try to reframe that to people. Yes, sir.
You know, it just occurred to me, I have a patient who is in rehab who has severe muscular dystrophy.
Yeah.
He's on a breathing tube.
Yes.
He's getting, he can't swallow, he can't talk, he is almost blind, he can't hardly hear anything. You know, his quality of life is just.
Actually, we can't determine quality of life. Only a patient can determine quality of life. That's an important concept to remember. You see people all the time who you think we are not in a position of judging another person's quality of life.
Absolutely, I
Yeah.
understand that.
Yeah. So what's the question?
But I guess my question is it, I'm wondering if I should have a conversation with him.
Absolutely. Do you want to keep doing this? Yeah, he may or may not. Yeah. And if those, I don't know if you can hear it.
I mean, it's really a good point. I thought, it's a legitimate point to ask, I don't know if anybody's asked him.
Right.
Or if, they're just, he's on life support, really.
I just want to ask the group if they could hear that question on Zoom. Raise your hand so we can see did you hear the question?
I see a couple heads.
Okay, so the question was, this man has somebody he's seeing as a patient.
Yeah.
Yeah, who's got I'm gonna say end stage muscular dystrophy.
And, yeah.
He's bedbound, he's blind, he's a breathing tube, he has a feeding tube. Communication is challenging, I bet at best.
Absolutely.
And the question was, should I have a conversation with him about what he wants? And the answer is yes.
Okay.
Yeah. And there may be conversations. He may have advanced directive forms. You don't know. Find out if he has a POLST form. Maybe that's on his chart.
No, that's good. Okay.
Yeah.
Thank you.
Yeah.
That's really well.
Absolutely.
Good stuff.
And one thing I learned over the years is you never can predict. You walk in and you look at somebody and say, wow, this looks bad. And they say, I'm fine. You open the door to the conversation and they say, oh, I'm good. Okay. So you have to train yourself to sort of take that part.
And so, excuse me, what happens if he says, I think I don't want to, it's a good point. I'm not sure I want to continue on.
Yeah. So I would do two things at that point. If you're comfortable having that conversation about now, let's talk about what that means. If not, get other people who can. And two is that would be appropriate to get a hospice referral at that point.
Yeah. He's taken massive amounts of Dilaudid.
Yeah.
So he's done a lot of need too.
Yeah. Sounds tough.
Oh, it is
Yeah.
really tough. It's
Yeah.
really difficult.
Yeah.
It's difficult for me, so this.
I bet. Okay, let's see, almost done here. Oh, assisted suicide. I believe assisted suicide is now legal in 11 states. Don't quote me on that. I haven't kept up with all the laws. California, it is legal. And the issues in California, or the rules are, it's got to be a terminal illness of a patient over 18 years old with mental capacity. Mental capacity, this is decision-making capacity, means I can take in information, I can manipulate that information, I can weigh the risks and benefits, and I can make a decision. That's what medical decision-making capacity means. Take in information, be able to manipulate it, reason, and then provide information back. If you have those three elements, you have decision-making capacity, which immediately means this is not appropriate for anyone who has lost it. People with advanced dementia, for instance. This law does not apply. It's a request for a prescription for aid in dying medication. You have to have an incurable, irreversible disease with a prognosis less than 6 months, which is the same criteria for hospice care. It has to be voluntary. You have to be able to self-administer drugs. So your patient, for instance, may not be able to self-administer drugs. There have to be 2 oral requests, at least 48 hours apart. There has to be 1 written request, signed and witnessed, and have to have 2 physicians certify a terminal illness. And one of those visits has to be with the physician and patient alone in a room, without any family or otherwise. It has to be, the goal is to make sure it's voluntary. And again, there's voluntary participation by doctors, hospitals, healthcare staff. No one is forcing the clinicians to be involved in this. And it's not surprising, there are rather few who want to be involved in this. Although since I moved here 2 years ago, I've heard that there are now physicians in town here who are making their whole practice out of this. Some of them have come out of a hospice background, but they've set up a practice where this is what they do. And they'll do this in the home, they'll set it up.
I have a question.
I'll hold those questions for a minute. I'm just going to finish, then we'll get into questions. So just final thoughts. The dying always know they're dying. Everyone fears emotional conversations. The path to serious conversations often needs someone to open the door. And that is sitting down and saying, Dad, it looks like you're not doing well. Can we talk about the future? Or Mrs. Jones, your last scans show things are not going in the right direction. Let's talk about what's important to you in the time you have left. Those are what I call opening the door conversations. Patients are free to shut that door in your face, and they often do. However, what I learned in practice was they shut that door on Monday, and a week later, they open the door themselves. Once you've opened the door, the wheels start turning. And they start thinking, what does this mean? What's going to happen? I'm not sure. And if there's one thing that I really learned is that knowledge is power. You know, we're all anxious about this, but getting the knowledge of what's going to happen, whoa, does that bring the anxiety levels down? So, and truth plus compassion is never wrong. Now, a lot of doctors provide truth without compassion or compassion without the truth. You need to have both. And I just like this quote from Kofi Annan: knowledge is power, information is liberating, education is the premise of progress in every society and every family. Okay. That's a heavy talk. Give me a second. And I'm going to ask the Zoom audience if they have questions first, just to keep them engaged.
I just had a comment about that last,
Comment, yes.
which is, I think it's rather than truth, perhaps reality plus compassion.
Okay,
You know, reality plus.
if that works for you, great.
Yeah.
Zoom audience, if you have questions, shout them out.
Either wave your hand in front of the screen or use the raise hand function if you know how to do that, if you have any questions. And I have a question of the Zoom audience. How was the audio? We thought we had everything right, but then we had to jerry rig things again. So that, I see a couple of thumbs up on that. Okay. And I see Don has his hand up. If you would
Hi, Don.
unmute yourself, Don.
I just wanted to say that the audio was fine. That was my little hand up. And if anybody wants to know, I know what happened to David's thumb.
Okay, questions from this group? Yes, ma'am.
So what is administered and how is it administered if you decide to have?
It's an oral, it's in.
Would you repeat the
I'm sorry, the
question?
question is, how is the aid in dying medicine administered?
Yeah.
It's an oral medication that's administered orally. It's a liquid.
Yeah.
Or it can be administered rectally through a rectal tube if the patient is able to open has the motor skills to open the stopcock for it to come in rectally.
Because the Swiss pod is different.
Switzerland is unique. They have their own thing there.
Yeah.
It's different. I don't have any experience with it. I can't comment on it. And I personally, because this was not legal in my practice in Wisconsin, I would get asked about it all the time, and I would say, we got to go to California. But I don't have any personal experience. It's a very difficult issue for clinicians. Years ago, there was a poll done among hospice physicians. The National Hospice Organization, it does not support assisted suicide. They think that everyone should be able to be taken care of without assisted suicide. The physician organization was polled, and this was over 20 years ago, and it was 50-50 who supported it. It's a very difficult issue. I've been involved in many cases of withdrawal of ventilators. It's very emotional to do that. It's a tough thing to do. And because 1 minute they're alive, you do something and now they're gone. And I know it was the right thing to do, but you go home and you think about that for a while. Assisted suicide is the same kind of issues. Yes, sir.
A quick one on, so if you're a early stage or mid-stage Alzheimer's patient,
Yes,
you really don't want to be around anymore.
right.
It sounds like because you may not be mentally capable of making a decision, it would still be illegal.
You have to.
Repeat the question.
The question was, if you have if you have dementia, early mid-stage dementia, the assisted suicide really doesn't work for you. Because you're going to lose the ability to have capacity. And frankly, at some point, lose the ability to self-administer.
So
So in those cases, what there's a whole nother subject we haven't talked about, which is voluntary cessation of nutrition hydration. And that is something you can put in your advanced directive. And there isn't a legal form specifically for it, but you can write that. And what that says is that if I'm at a certain point, don't feed me and don't water me. Don't bring me food. And it's about 2 weeks. If you took a normal person and didn't allow them any food or water, they would survive about 2 weeks. We learned that with the famous case of Karen Ann Quinlan. She lasted 13 days. So that is a growing movement in the dementia world, is voluntary cessation of hydration nutrition. Not the most pleasant thing in the world. Also not the most unpleasant. There are plenty of medications, and hospices will support this. And by the way, not all hospices support assisted suicide. I mentioned that. So if you're enrolling in a hospice program and that's something you're interested in, you have to find out if they will participate in that or not. So that's a case-by-case decision. Yes, ma'am.
When a patient has a less than 6 months to live diagnosis,
Yes.
they have to find a physician that will prescribe the medication.
Yes.
And then it sounds like they have to request the medication verbally
Yes.
twice within 48 hours.
Yes.
And then they can take the medication if they're able to administer it to themselves.
Great. The question for the Zoom audience is basically restating the criteria for assisted suicide. I urge you to go on. There's a website there's a bunch of websites on it. You can look up the specific rules again. Go ahead.
The question is there within that 6 months or less of living prognosis?
Yes.
Is there any time point where you have to wait till you have less than 3 months?
No.
Right?
There is no. If you've been given that diagnosis and you meet all the other criteria, you can do it at 5 months and 11, 5 months, 11, whatever. Yeah. Or you can do it on the last day. A fair number of patients who request the medication never use it. There is, those of us who are control freaks, and I wouldn't know anything about being a control freak. Having the medicine in my bedside cabinet may be all I need. Knowing I could do it if I wanted to. And what's that? And somebody said something. That's been known for a long time in the literature. It started when the first law came out in Oregon, they found that. And the numbers continue to be very small. We're talking about hundreds of people, not thousands, in the state who do assisted suicide. I can't remember the California numbers, but it's in hundreds, not thousands. Yes, again.
My experience with hospice was a long time ago, but I don't think in that period, we didn't have any suicides, even though patients would talk about suicide. What we really understood them to be saying is, we're scared and we want to be assured that we will not suffer.
Yes.
Hospice provided a
So-
good amount of palliative care.
So not a question, but a comment of that in hospice, in end of life, people talk about suicide all the time. And one of our jobs was to assess people of how serious that suicide threat was. It's almost never serious. It's almost, not always, a call for I'm lonely, I'm scared. And that's, if you have a support system, whether it's through hospice or family, that can usually take care of it. I was very fortunate. I never had never had a suicide death, but one of my colleagues did. It affected him very deeply. He was an oncologist with a breast cancer patient. And he found that was really hard. So it happens. John, do you have a question?
I'll come back to it.
Okay,
There are 3 hands up.
3 hands up. Great. Come on.
Pam and Faye and Alvin. So if Alvin's unmuted right now, I think.
Okay, should I go first?
Well,
Yes.
I think you were third in line. Actually, Pam was first. If she's
Right.
still.
So go ahead.
Oh, what percent of medical school is devoted to palliative care training?
Very little.
Is there a movement to increase the percentage of training around that content?
Yes, but it's very slow. And it's very, medical school curriculum, trying to change medical school curriculum is like moving a cemetery. It's very difficult. At the medical school I worked at for 25 years, I put in this big curriculum, starting in the first year through their last year. And within 5 years after I left, even though I left a whole group of people doing what I did, 3/4 of the curriculum was gone. Keeping that part of the curriculum that you want in place is a real challenge for what I'll call fringe topics. And frankly, I'm less concerned about the medical school curriculum than I am about residency curriculum, because that's where people develop practice patterns. There's been more movement in the residencies, particularly in things like family practice, internal medicine, to do training of communication skills. That has been, that's become much more common. And that's a really good move. And the other piece that there's not been enough work on is been in faculty, is training the faculty to do this. When I retired from medical school, I stayed in practice another 8 years doing consulting work. And a lot of that consulting work was running training seminars for people in practice to do these communication skills. And I wouldn't get up and give a lecture. We would do role playing. I would put them in the hot seat and they'd have to play doctors and patients and learn how to do these conversations. And they were inevitably, people were shocked at how bad they did and came to recognize how bad they were. But we don't have nearly enough of that going on, and there needs to be way more. But it's very hard. It's very hard to do this work. It's very hard to get the money to do this work. You know, it goes against all of the grain of medicine. It's not about making money, I'm sorry to say. And our healthcare, and as the healthcare system has, in my view, deteriorated in the last 20 years, this in many ways I think we peaked for a while and we've actually are moving away from it again. But that's my personal value.
It also goes against medicine because medicine is save a life.
Well, it goes against it. So John brought up, this is Dr. Kern, a pediatrician and neighbor of mine. John brings up the point that it goes against medicine. And I would argue that that's a mythology. It goes against medicine. Medicine is designed to take care of people, good, bad, or otherwise. And medicine historically always recognized that people did what? They died. And if you look at all the old-timey photographs, old-timey meaning before the 20th century, it was always the doctor at the bedside. Doctor was sitting down. What's the vision of the doctor in the 20th and 21st century? Standing up across the room, distance, not having that close relationship. So the idea that we always used to say, well, it's against medicine to let people die. Excuse me, I don't let people die. I help them go I honor what's happening in the natural process. So John, you and I can disagree with this over coffee, but I think that's the wrong way to think about it. And I want to get back to, there was 2 other people on Zoom who had questions.
One was Faye.
Faye.
Oh, hi. First of all, I wondered, the assisted suicide is not the term that is used anymore, except for our opponents. I've been an advocate of assisted suicide, or whatever you want to call it, medical aid in dying, for 40 years now. And the term is medical aid in dying. In California, it's called the End of Life Option Act. The statute specifically says it's not suicide for insurance purposes, and it's not suicide on the death certificate. And as an act, it's not the kind of thing we think of as suicide, which is done by somebody who has mental problems, often alone, and most often violently, jumping, shooting, overdosing. This is a controlled substance. Most people surrounded by their loved ones when they do it, and they're happy to be out of this world that way. So that's the first thing. And I just wondered, in your talking to patients about their options, do you suggest the End of Life Option Act? And if they don't know about it, how would they find out about it?
First, Faye, thank you very much for the clarification. You're absolutely right. The assisted suicide is the old terminology. So thank you for clearing that. The second is, I don't practice and have never practiced in California under this act. So I had no opportunity to advise patients about the act because I lived in the state of Wisconsin where It was not a legal act. So I will have to punt that question, and you can ask that question to California physicians who have practiced during the act has been in place. And I don't know what the practice is. My guess is it's highly variable. There are clinicians who on religious, personal, or whatever reasons don't agree with it and will not bring it up and will discourage patients from it. And there are others who will bring it up, probably if requested. My guess is there are very few who would bring it up as an option, just bring it up on their own. That would be my guess. Okay,
Well,
somebody,
there is
go ahead.
some law about that in Australia. It seems that's what a script says. We tell the patient all options at the end of life, but do you tell them about the End of Life Option Act? No, unless they ask for it. So that doesn't
Right.
to me mean like they know all options.
Right.
And then
I-
also, by the way, somebody in Wisconsin or Missouri or any place else can skip the residency requirements in, I think it's Hawaii and Vermont. So actually, the residence
Nice to know.
requirements are no longer valid.
So my friends on Zoom here from Wisconsin, I hope you're paying attention to that.
And also, I have endowed a lectureship at UCSD for the medical students. I'm not sure they get it, but it's on medical aid and dying, just so they know that that's an option, and also the faculty, because when you don't know about it, you really deprive people of the possibility of thinking about that choice. And for most people, it's a pretty happy choice. And
So
then, of course,
go ahead.
I was just going to say that the duty of a doctor is also to relieve suffering. And for many people, that is a way of relieving suffering.
Absolutely. You brought up a different interesting issue, is that this issue of all treatment options. So it's very common. It's standard. In fact, if you come into a hospital, let's say with dementia, and your spouse or a nursing home sends you into the hospital, you'll come in the hospital, antibiotics will be started in the emergency room, you'll be sent upstairs, and no one has given you the option of not starting antibiotics, which is perfectly legal. We rarely present all the options, particularly in these cases. We do what we think, the health profession does what we think is right, but we don't bother with that silly issue of talking to families or surrogates about what all the options really are. So that's another issue when you're in the ER and somebody is talking to you, is make sure you understand and ask them are there other options? Do I have to do this?
Yeah.
Because
But
in most situations, the answer is no. Okay, other question.
Alvin and James.
Yeah, okay. So this is a little bit of an awkward question, but so I'll phrase it this way. So when I was very young and talking to older people about their loved ones who were at end of life, had, let's say, the proverbial 6 months or 3 months or whatever, and were in intense pain, that when a doctor sees a patient like that who's going to die, who's just suffering and suffering and suffering, often what would end up happening is that that person would somehow get overdosed with some pain medication and would die. And that somehow or other, the people who were there and were sympathetic would see to it that the right thing was, quote, done. Have you heard of that?
Of course, I've heard of it. I've seen it. I've reported it because it's illegal. And it's unnecessary also. And there's a whole mythology around this issue as well. The mythology is that it's a very fine line between keeping somebody alive and overdosing them with opiates, we say morphine. In fact, it's a gulf. It's not a very fine line. It takes a lot of intention to want to do that. And many clinicians who've done it think they crossed the line. I really doubt it. But I was in a situation where I was up on a hospital unit and I found that the doctor was bullying the nurses not to talk about it, but he was having them overdose patients. He was committing murder, in fact. And I reported that to the hospital and they took whatever measures they were going to take. And those patients, I'm sure, were suffering. I have no doubt about it, but that's not our role in life. So that's what I think about that issue. It's a huge concern, but we call it the last dose effect. The person who gave the last dose and then the patient died always feels guilty. Am I the one that did that? Very rare that happens. Yes, sir.
You're putting back on pulse.
Back on Pulsed.
Yeah, so are you suggesting that if you're perfectly healthy,
Yes.
whole but healthy, that you don't need one, or you?
Pulsed is only for people with a terminal illness and a 6-month prognosis.
Okay.
Only for those people.
So what is it you have on your refrigerator that tells the emergency people what to do? You said.
I don't have anything on my refrigerator. I have my California statutory advancce directive in an envelope in the freezer, as well as my wife's. We both know it's there.
It's just your directive.
It's just my directive. Yeah. And you know, but that's not a bad thing, is I could get a magnet that says, look here. Yeah. Okay, other questions from Zoom?
Yeah, Jane has a question and then Sandy.
Okay.
My question, I just recently came out of surgery, and as a result of some decisions that had to be made, both of my children suddenly have become rather reluctant to have the responsibility of making decisions when the big one comes, because this was life-threatening. And so suddenly I am looking at this document and trying to figure out what I can do to help my children make a decision on who feels that they can or want to do this. And is there
This is very common. It's very common, and not for good reason, that family members don't want to take that responsibility on. It's a huge responsibility to have to speak for someone else and make these decisions.
And they got into a controversy between each other on a non-death situation. It was a matter of how much and what kind of post-surgery medication to take.
Yeah.
And it was enough to trigger them not wanting to do that again.
Right. If you're in a, well, so just a couple of recommendations. Number one, if you're in a position to be in the same room with them at the same time and have this as a conversation and talk about and have them not one-on-one, but have all three of you together, you describe your concerns and let them describe their concerns and see if you can find a middle ground. And then figure out if one of them is willing to be the agent and one is a backup. It's much more helpful to have one person than have two people, because two people rarely agree. Well, that's not true, but it's better to have one person and the other person say, you know, I'm fine with that. My sister is the one, she can do it. She can do it. If they really can't come to, if they can't agree and don't feel like they want to take on the responsibility, then you can find someone else to do it. And if you've got a good friend, wherever in your network is, find somebody who would be willing to be that person and tell your kids, if you can't do this, I'm going to get cousin Jane to do it. And she's agreed to do it. And they may say, great, thank you. But it doesn't have to be the children. It doesn't have to be the spouse. I've seen all kinds of different arrangements.
And then I want to share with you a experience I had at Estes Park and Longmont in Colorado.
Can I hold on the experience and just get, if there's another question there? Thank you. I got time. They're telling me I've got time for one more question.
Sandy had a question.
Yes. Thank you. Mine isn't so much a question as a remark. One thing, I'm here from Oregon, and we too now have added, or rather removed the residency requirement. It's quite recent, so I'm not surprised you didn't know. But I also wanted to mention these the option. I'm sorry, I'm having a senior moment over the name of the country. It begins with an S and it's up in the Alps.
Switzerland.
The Switzerland option, thank you all, you don't need to be 6 months away, and you, I found out about it from a wonderful book written by a woman who is an author. I'm not remembering her name, Amy something. But her husband got diagnosed with dementia, and he said, I don't want to go through this downward thing. I want to die now. And she helped him. It's a very complicated, it took several months, but interviews and all kinds of things. But they went to Switzerland. He was still, he had issues, but he was still of sound enough mind, and they allowed him to end his life there.
Very nice. Thank you for that comment.
But sorry?
I said thank you for the comment.
Yeah, I really recommend this book. The title of it is something about love. And yeah, anyway.
They tell me my time is up. So I can answer yours. We can do
One more question.
One more question.
You know, you were mentioning withdrawing sustenance.
Yes.
Water sustenance. So when you do that, do they put the person under, how does it?
So if you withdraw food and nutrition, the primary symptom is a dry mouth. And if they're already bedbound, they're not going to get dizzy because they're not standing up. But the primary issue is dry mouth, and you can alleviate that with oral swabs, liquid swabs, that's fine. But no, they're not put under to do that. We don't anesthetize
Right,
people.
so do they start to feel?
They get sleepy.
Oh,
In a very short period of time, they get to sleep and go to sleep.
Okay, so they're not in pain.
No.
They're not distressed.
They're not in pain or distress. And if
true.
they are, there's medication for that.
Oh, okay, good.
Not true.
Good to know. Yeah.
I noticed that my brother is on the call, so I on Zoom, I wanted to say hi to my brother Ron, and this is a big day for us. It's the 44th anniversary of our father's death was today. So Ron, best wishes. Look forward to seeing you next month.